Do you hear me well?
Yes, we hear you and we see case one and two.
Good, perfect. Wherever you are in the world right now, hello, and whatever time it is, thank you, Kish, and the organizing committee for letting me share my experience here. And this is going to be a different pace in terms of the images, and you'll see. So I want to share two real life cases that illustrate dilemmas in neurodevelopmental outcome. The, the two fetuses have similar gestational age, 24 weeks of gestation. Case one on the left shows subtle subthalamic lesion, while case two has diffuse bilateral parenchymal injury in bilateral pericylindric areas. How can we differentiate between these cases and predict the neurodevelopmental outcome? In the next 20 minutes, I'd like to share my journey through complex cases that highlight the everyday dilemmas faced in fetal imaging and prognostication, and we'll try to put the puzzle together. Fetal MRI has become a cornerstone for prenatal imaging, playing a crucial role in accurately diagnosing pregnancies, and I think you've seen it throughout this morning or day, infecting congenital anomalies. The findings from MRI facilitates precise counseling and management of brain abnormalities diagnosed before birth. Why fetal MRI? It complements the anatomic data offered by ultrasound and CNS evaluation due to the superior soft tissue contrast capabilities, multiplanar acquisitions, large field of view, and sometimes detecting subtle anomalies, especially in the susceptibility sequences consistent for hemorrhage. And especially in Israel, there's an increasing demand in high risk pregnancies. So MRI is a fundamental diagnostic tool to assess fetal anomaly following a detailed ultrasound assessment, the so-called neurosonography of the brain in cases of suspected anomalies. And the integration of the two techniques is warranted to improve the predictive accuracy. So going back to these fetuses, both of them were referred for MRI on case one on the left because of echogenic subependymal caudothalamic mass protruding into the right ventricle, and it was actually suspected of being a SIGA. While the second case demonstrated diffuse perisylvian parenchymal echogenicity with some blood. MRI is the next step in evaluating any definite or potential abnormality identified through fetal neurosonography. And I'm very lucky to work with amazing neurosonographers that make these very subtle diagnoses. So this process aims to verify the presence of suspected abnormalities and to specify their severity and their extent. The fetal MRI referral guidelines are not well defined, and they vary from various countries depending on local resources. There is no international consensus on whether to refer patients for fetal brain MRI, and this results in varying practices. As you can see, there are inconsistent practices across the world. There are different thresholds for ventriculomegalies. In some places with excellent neurosonograms, they will not even refer them to MR for 10 millimeter. There are borderline anomalies like cavum septum pellucidum that are not that they will send for MR and others will not. And this is the summary of the 221 European SPR Fetal Task Force guidelines for indication for fetal CNS MRI, a family history of severe brain disease, maternal infections, and various brain anomalies as verified here in a colored way. And we've all seen examples of it throughout the day. So going back to the first case, it was referred due to an echogenic mass suspected of a SIGA. And the first and second trimester ultrasound were normal. She had a normal the CMA was negative, and and you can see on the sagittal images, there is a hypointense cystic and solid subependymal lesion, that you can see it here, arising from the caudothalamic notch. On the susceptibility images, There we go. On the susceptibility images, you can see them here. The hypointense signal is consistent with blood products and demonstrates evolution with time. Diffusion-weighted images demonstrates restriction, probably related to EPI artifact because of the inhomogeneity of the field. And there is a mild focal dilatation of the ipsilateral frontal horn, probably representing focal atrophy. The second case was referred due to diffuse parenchymal echogenicity, suspicious for multifocal ischemia. She had a previous history of termination of pregnancy due to severe heart anomaly. The grandmother also had a history of termination of pregnancy due to brain anomalies, and both early scans were normal. In the second scan, neurosonography demonstrated these echogenicity. Asymmetric frontal horns are suspicious of diffuse blood, and there were focal areas of cortical involvement and cortical thickening. And here you can see that there is suspicious of also polymicrogyro or an abnormal gyration pattern. Only when we use the more advanced sequences, and of course, the backbone of all the images is the single shot T2, but the critical additional sequences of the T1 weighted images can be performed in many ways, as we saw today, T1, 2D, gradient echo, inversion recovery, or fast spin echo techniques. And they're quite hard to achieve, but you can see the hyper-intense diffuse signal consistent with the blood. And their diffusion-weighted images, so we can see them here, can prove the detection of ischemic tissue changes as well as documentation of the hemorrhage and the calcification. And you can see how diffuse this damage was, including the left frontal region. The T2 gradient-based sequences can also be complementary for looking for hemorrhage and calcium and demonstrating blood products in the extraaxial, interhemispheric, and frontal regions, as we can see here. So this, as we said, the T2 technique is the mainstay of fetal neuroimaging, and we've talked a lot about that, so I don't think I will dive into that. And it just to have the importance of how the technologists need to adjust the image angle based on the most recent acquired imaging. And it's all a game of between image resolution, speed of acquisition, and an SNR. And these are the main variables that determine the image quality. So the effort should be made to achieve a balance among these three without surpassing established SAR limits. And this is quite a difficult game to play with, and we need a lot of help from our amazing clinicians. I'm just going to touch on advanced imaging, just about the importance of, and we saw the beautiful lecture by Gregor before about the pushing into the early scanning and the importance of segmentation, motion correction, and 3D reconstructions, radiomic integration to further improve the image quality and time. This is far from being accessible in my daily work life. So the future is not quite here yet for me for the day-to-day life. So coming back to our two fetuses, even though it may seem like one of the fetus had very focal parenchymal involvement and the other demonstrates diffuse injury, they were both diagnosed with mutation in COL4A1 gene. And the neurological involvement in COL4A1, whatever related disorders, is extremely variable and depends on the timing and the insult and the severity. And it includes various types of malformations of cortical development. And this is also true for the fetuses, and the in utero involvement has a wide range of injuries, which essentially represents a continuum of brain injury depending on the severity of the insult. Okay, so often when we see a mix of cortical malformation, for example, schizencephaly and heterotopia, and especially with blood products, this should guide us to think about COL4A1. And the phenotype can be variable with a broad intrafamilial variation and reduced penetrance. The explanations for malformations of cortical development in COL4A1 and 2 related diseases, that there is an instability of the PL membrane in the cortex, which serves as an anchor point for the radial glial cell on which the neuroblasts migrate to the position to the brain cortex. This instability of the basal membrane may affect many parts of the body with a broad phenotypic spectrum that cannot be predicted throughout life. So both these fetuses had a potential of having a very bad prognosis. When we looked at the mother, the MRI of the mother in case 2, 34-year-old, in the previously described one, during the genetic evaluation, that was before we knew she also harbors the same gene, we found that she was worked up for a white matter T2 hyperintensities, and these are likely consistent with small vessel disease. And this is part of the COL4A1 mutation that was inherited by this normal developmental mother. And this demonstrates the complexity of fetal prognostication during pregnancy and the importance of thorough neurological investigation which harbors variable phenotypes manifestations as described. As described in this familial phenotypes from fetal to adult by our group. Both of these cases are part of the ongoing understanding of various manifestations of perinatal stroke. Advances in imaging techniques and increased availability enables us to what we called previously as idiopathic hemiparetic CP or congenital hemiplegia are actually due to perinatal stroke. And the term of the periventricular venous infarct has been described in term children presenting with congenital hemiplegia and is believed to represent an in utero version of the same venous stroke. PVI accounts for 22% of presumed perinatal ischemia. And these are various examples of periventricular venous infarctions that we had in the past years, and they are come in various shapes and patterns. They can be very subtle with or without hemorrhage. This is another example. It's a very subtle example of PVI. It's compatible with an infarct. Again, you can see the focal dilatation of the right frontal horn, and this kind of shape in the tent-like shape in the parasagittal image, which I find the most helpful in these cases. These are very, very subtle abnormalities, and they were picked up by the astute neurosonographers with a mild irregularity on ultrasound. They may have no clinical implication, but it's really important to make sure that the genetics don't harbor any of the other genes that we have just talked about. In this child, he had a normal exome. This is his follow-up at 30 days, and he's normally developing postnatally at 2 years of age. So it's challenging to prognosticate in these very subtle cases, and you really have to rely on the MRI findings and the correlation to learn long-term outcome. And this is the one thing that is really missing in many of our journeys. To improve prognostic counseling and provide guidance for families throughout pregnancy and the postnatal years, it's essential to establish a fetal radiological neurological correlation using appropriate outcome measures in large cohorts with long-term follow-up. These will enhance the understanding of radiological patterns that aid in prognostication. In our recent papers, we looked into fetuses and babies that had hemorrhage that were born at term. And the anterior horn width, among other features that cannot be diagnosed prenatally, reflecting the ventriculomegaly severity, was strongly correlated with an unfavorable outcome in children with perinatal intracranial hemorrhage, as well as many other features here. As you can see, the Vermean hemorrhage, thinning of the corpus callosum. This is an example that prospective long-term neurodevelopmental outcome in perinatal intracranial hemorrhage improves the ability to prognosticate. So we really need these large groups of follow-up and neurological follow-up. So fetal MRI cannot be relied upon as a sole diagnostic modality, even in the best hands, the best protocols, in a place that has a lot of experience with a 3 Tesla, the technology is set up. We rely on precise neurosonography, indications and availability in these different places in the world have different abilities for that. We also are very privileged to have genetic counseling, including next generation sequences. And we also have, and it's important that there is counseling and clinical management according with national legislation as it is in different places. We still need to validate the methods for predicting abnormal or delayed postnatal neurological development, and these are with the follow-ups. I will run into the last case. This is a case of a twin pregnancy that was found to have a mutation in TABA-BB gene following a previous pregnancy of the same gene, just to show the complexity of twin imaging and how difficult it is. In this case, both fetuses demonstrated midline distortions, interdigitation, the dysmorphic basal ganglia, again, some mild commissural hypoplasia, and a wide spectrum of dysgyria. It turns out that the mom and the grandmother displayed similar findings. This is the mother, and this is the grandmother, both of them high functioning. The grandmother is a judge in Israel. And in this case, they completed, and both of these babies were born. And this case demonstrates the importance of identifying familial subtle radiological biomarkers, which represents mild tubulopathy. And this, again, are some of the features that we can do in order to refer for reasons of evaluating parental imaging. So, and my last slide, in the fetal world, there is no single tool or specialty that has all the answers. It's just like a piece of puzzle. Sonography, fetal MRI, genetics, and the prognostic insights of fetal neurologists, along with the strength of our multidisciplinary team together, it can help us form the clearest picture possible for each family unique journey. Our continued challenge is to improve these guidelines, enhance the collaboration, refine the prognostication, and always put our collective expertise to work so we can counsel and care for children with confidence and compassion. Thank you for joining me in assembling this challenging and evolving puzzle. Okay, and I wish to thank the many, many, many people I work with, the amazing neurosonographers, pediatric neurologists, pediatric neurosurgeons, genetics, pathologies, and special thanks to Steffi Lipson, who's helped me put this whole talk together. And thank you, Kish, for the amazing opportunity to speak to you. Now, be happy to answer